Good afternoon, everyone. I think all are hungry now, so we will try to finish early. So let us discuss case-based discussion in heart failure. So all you know, heart failure is globally very much affected patients. Around 30% of the global population by end of 2025 will have heart failure. It is progressive disease. 9 out of 10 patients having symptoms despite taking treatment. And it is very deadly because as earlier speaker also told, heart failure mortality is more even than cancer. So 5-year mortality of heart failure exceeds the prostatic cancer. And treatment is costly. Of course, we know most of the time, 10% if you see the total patients of heart failure are dying in first hospitalization, and survival after second hospitalization is also less than 18 months. But it can be prevented and treated. So if we see the data globally and Indian data, so if we compare, Indian data is showing less than around 53 years of the patients are developing heart failure compared to global where age is very high. In hospital mortality is also very high in Indian population, around 30%. And post-discharge mortality is also more compared to global. So in India, heart failure is affected in very young age and very high mortality, in hospital mortality as well as post-discharge mortality also. This slide, Mihir bhai already discussed the 4 pillars of heart failure. So let us discuss the different heart failure case scenario. This is first case where female 66 year, NYHA class 2, ejection fraction is 28%, blood pressure is around 100 by 74, anti-proBNP level is high, and serum creatinine is 1, pulse rate 92, hemoglobin is 8.5. There is no history of diabetes. History of hypertension was there since 15 years, and 2 hospitalization for heart failure in last 12 months. So she was on this current therapy, ramipril, metoprolol 100 mg, torsemide, eplerenone, and amlodipine. So what can be done better for this type of patients? So if we see blood pressure is 100 by 74, so we all think blood pressure is less. So what change we can do here? Is already we discussed the 4 pillars. We can add ARNI. In spite of this taking ramipril, we can change the ramipril to ARNI. Then metoprolol we can continue. Here patient is class 2, so maybe euvolemic, so we can decrease the dose of diuretic now. And we can add SGLT2 receptor inhibitor, and her hemoglobin was low. So let us not forget this thing, because most of the time patient is coming with recurrent heart failure just because of anemia. So we have to replace the iron also. So why sacubitril valsartan despite BP is low? We will see later. First we can see this. ARNI can cause potent after-all reduction and blood pressure reduction also. It also promotes diuresis. It may worsen GFR initially, but if we give continuous, then it can preserve the kidney function in the long run. And it also causes less hyperkalemia compared to ACE inhibitors and ARBs. So this is the study which was done in Paradigm HF trial, and some sub-analysis was done in which they took different systolic blood pressure group of patients, and they have seen CV death and heart failure hospitalization. They have compared ACE inhibitors enalapril versus sacubitril valsartan, and they have come to conclusion that even in patient with persistently low systolic blood pressure after treatment, sacubitril valsartan was superior compared to enalapril in reducing the mortality and morbidity. This is another sub-analysis was done, and they have seen there is no clinical significant worsening with sacubitril valsartan as compared to enalapril. In Paradigm HF trial, they also studied this clinical benefit of ARNI versus ACE inhibitors enalapril, and they have came to conclusion cardiovascular death, heart failure hospitalization, overall mortality, heart failure death, and sudden death, all are less in ARNI group compared to enalapril group. So if BP falls further on sacubitril valsartan, what will you do? So we have to see these factors, whether patient is having symptomatic hypotension or not. That is more important, because sometimes we are seeing just number, okay, BP is 90 systolic, let us stop the drug. But this should be take care. We have to see whether patient is having symptomatic hypotension or not. If patient is having symptomatic hypertension, then we have to see patient is volume depleted. We have to check for diuretic therapy, dietary salt restriction, and is there any volume loss like diarrhea or vomiting is there or not. So we have to do the dose adjustment of diuretics, concomitant other antihypertensive drugs, and treatment of other causes of hypovolemia. Dose reduction of sacubitril valsartan, sometimes we have to do, or sometimes we have to stop also if patient is symptomatic because of hypotension. But they have found permanent discontinuation of ARNI usually was not required. And before starting ARNI, we have to take care with volume status and sodium status. So if both are corrected, then we can start ARNI. So this ARNI will reduce the morbidity and mortality and prevent the clinical worsening in heart failure patient. That's why it is preferred as a first line of therapy in compared to ACE inhibitors or ARBs. Second drug, SGLT2 receptor inhibitor. This study, DAPA-HF trial, was done across 20 countries, and they have randomized the patient, and they have studied the primary and secondary outcome, and they came to conclusion in patient with heart failure and reduced ejection fraction, whether they are having diabetes or not. Dapagliflozin reduces the risk of worsening of heart failure or death from cardiovascular cause compared to placebo. Third point, iron replacement therapy. As we all know, this is the meta-analysis was done with some studies, and they favor the iron replacement therapy compared to placebo in developing or worsening of the heart failure hospitalization. One more analysis was done for hospitalization for any other cardiovascular cause, also significantly less in patients who already treated for iron replacement therapy compared to placebo. And this is death due to any other cause. Although there is not much significant difference, but still they told FCM means carboxymaltose or other iron therapy replacement is better in heart failure patient if they are having anemia. So this is case scenario. We again came. This is the change we can do, and we can treat heart failure patients better. So now we will discuss some other cases, like if you are getting some patients with heart failure with reduced ejection fraction, patient is euvolemic and blood pressure is low, what we can start? So first of all, we can start with low dose of ACE inhibitors and low dose of beta blocker, because here patient is euvolemic. So we can start beta blocker directly. Then we can take that patients to follow up and normally check the blood pressure and other renal parameters. If everything is fine, we can increase the dose of ACE inhibitors. We can also add mineralocorticoid receptor antagonist and SGLT2 receptor inhibitors. Again, follow up after 2 weeks. Again, we can increase the beta blocker and ACE inhibitor dose. Or if BP is stable, we can switch to ARNI also. This is another case scenario where patient is euvolemic and blood pressure is normal. So now here we can directly start ARNI, SGLT2 receptor inhibitor and beta blocker, because patient is euvolemic. Again, if patient is in heart failure, better not to start beta blocker and first make decongestion first. Then after follow-up of 1 to 2 weeks, if renal parameter, potassium level and volume overload is okay, then we can add MRA and we can increase the doses of beta blocker. And again after follow-up, if everything is fine, we can titrate the dose of ARNI and we can increase the dose of aldactone and beta blocker. This is third case scenario where patient came with volume overload and normal blood pressure. So here our first drug is diuretic. We have to either give IV or orally diuretic. We also start SGLT2 receptor inhibitors, ARNI and MRA, because all these drugs have some diuretic property. So for volume overload state, we can start all these 4 drugs. Then follow up after 2 weeks, and if renal profile is normal, we can increase the dose of ARNI. We can add beta blocker now because volume overload is now reduced. And then after again follow up with 2 weeks, we can reduce the dose of diuretic now. That is also very much important. If patient is getting clinically better, then we have to reduce the dose of diuretic and we have to titrate or increase the dose of other drugs like ARNI, beta blocker or aldactone. This is case scenario 2. The 72-year male post PTCA with ICD implantation. Ejection fraction is 30%. Blood pressure is normal. Heart rate is 80. Anti-pro-BNP is 450 picogram per milliliter. Potassium level is high. Creatinine is again 1.8. And patient is having diabetes. So this patient is taking enalapril, bisoprolol, aldactone, Lasix, aspirin and rosuvastatin and sitagliptin plus metformin combination for diabetes. So what would be the choice for further treatment in CKD and diabetic patient? So this is the change we can do. We can increase the dose of beta blocker. We can change rosuvastatin to atorvastatin, as Nilesh Bhai also told. Rosuvastatin is better to change to atorvastatin in CKD patient. And we can add ARNI. So you people think, why ARNI? And another drug we can add is SGLT2 receptor inhibitor. So this is DAPA CKD trial was done. In this trial, they compare the dapagliflozin in CKD patient with or without diabetes, and they have studied among patients with CKD the risk of any composite kidney or cardiovascular outcome or death was significantly less in dapagliflozin group compared to placebo group. Again in Paradigm HF trial, they have seen incidence of impaired renal function was less in sacubitril valsartan group compared to enalapril group. And discontinuation of the ARNI was less in this type of patients compared to ramipril group. Again, hyperkalemia incidence also lower in as compared to ACE inhibitors or ARBs in ARNI. So this is also helpful. If patient is having hyperkalemia, then you can also switch over to ARNI, because as compared to ACE inhibitors or ARBs, this ARNI having less hyperkalemia. But this type of patient needs regular creatinine, urea and potassium monitoring specially. So this was the statement was given in Association of Physicians of India, where they are saying ARNI, SGLT2 receptor inhibitor and bisoprolol is having some renal benefits in CKD patients. But here you have to see for this all parameters like creatinine, potassium, and you need to do dose adjustment if required. This is, we will not go much detail in this. Then how to do heart failure management in CKD patients. So if any patient is having CKD and we have to do heart failure management, then first of all, we have to see the NYHA class, CKD stage and potassium level. Then we can initiate ARNI as a low dose. We can add beta blocker and SGLT2 receptor inhibitor. As sir already mentioned before also, okay, while starting ARNI, maybe there is some rise in creatinine is there, but we can continue up to 20%. Rise is okay, but beyond 20% we have to be cautious. So we can continue ARNI despite rising the creatinine level, but we have to check regular GFR. If it is stable, then we can continue because it has some renal protection. So we can continue ARNI, and we have to see the potassium level also. If potassium level is within range, then we can add mineralocorticoid receptor antagonist, and we can add beta blocker and then up titrate the doses of beta blocker. This is case scenario 3, where 70-year-old lady having dyspnea and history of hypertension since 10 years, and she is obese. Examination is showing blood pressure is 150 by 100. Heart rate is 80 beats per minute. Echo suggestive of normal ejection fraction 55%. NT-proBNP level is high. eGFR is 40. And her hemoglobin is 12. So she was on current medicine of telmisartan 40 milligram one daily and amlodipine 2.5 milligram one daily. So what therapy can we plan in present cases of heart failure with preserved ejection fraction? So this is the universal definition and classification of heart failure, where they define the heart failure in these 3 different categories: heart failure with reduced ejection fraction, heart failure with mildly reduced or mid-range ejection fraction, and heart failure with preserved ejection fraction. So in this case 3, therapeutic strategy is diuretic for congestion, SGLT2 receptor inhibitor like dapagliflozin or empagliflozin, and control of the comorbidities like diabetes, hypertension, and atrial fibrillation if patient is having any arrhythmia. So SGLT2 receptor inhibitor is also class 1A indication in heart failure with preserved ejection fraction patients. The SGLT2 receptor inhibitor having minimal effect on blood pressure, it promotes the diuresis and it protects the kidney on long term. They may prevent the hyperkalemia associated with other agent also. So this is the mechanism of SGLT2 receptor inhibitor in heart failure. It increases the glucose removal and increase the sodium removal. It also causes decrease preload, decrease afterload, increase cardiometabolic efficacy, decrease the risk of arrhythmia, increase the arterial wall structure and functions, and in kidney it decreases the glomerular pressure and also decreases the albuminuria. So this SGLT2 receptor inhibitor is having wonderful effect on cardiovascular as well as renal outcomes also. So this is the hemodynamic effect of our guideline directed medical therapy. ARNI having much BP lowering effect. So you can add ARNI if patient's BP is very high. Then you can also add AC inhibitors or ARBs, beta blocker. Although beta blocker is not first line therapy in hypertension patients, but any patients with LV dysfunction, you have to add beta blocker also. Then diuresis, if we see maximum diuresis is with SGLT2 receptor inhibitors and ARNI. So if any patient is having volume congestion, we can start these 2 drugs before than any other drug. Also, they have very much kidney protections. ARNI, AC inhibitors, SGLT2 receptor inhibitors, and even mineralocorticoid receptor inhibitor also. If hyperkalemia, then we have to avoid for mineralocorticoid receptor inhibitor. ARNI is having less hyperkalemia compared to AC inhibitors and ARBs. And if heart rate is high, you have to add beta blocker. Here we have to just take care because beta blocker is again first line therapy. So if BP is normal range or patient is not having congestion, means not having volume overload, first you have to add beta blocker. Heart failure hospitalization, heart failure management during hospitalization. How to manage heart failure in hospitalization. So we already discussed these 4 pillars Mihir bhai also told, this four pillar is very much important in management of the heart failure. But what is the first drug and which is very much important in treating the heart failure? That is diuretic. So this is one study published, we are already talking about door to balloon time, and Mihir bhai also told time is very much important in overall. If we see cardiology, time is more important. So in heart failure also, if any patient is coming to frank heart failure to your hospital, this is the study. They studied furosemide, and they have told door to furosemide time and clinical outcomes in acute heart failure patient. So this is very much important thing. If you receive any patient with heart failure, how early you are giving furosemide. And they came to conclusion, this door to furosemide time, if it is less than 1 hour, it was associated with lower short-term risk of heart failure hospitalization and cardiovascular death. So time is again important here also. So again, heart failure management during hospitalization. So as Mihir bhai also told, previously it was like one by one drug we are giving, but now all drugs you can start even during hospitalization also. Just you have to see patient should be in off inotropes, patient's systolic blood pressure should keep more than 90. Then we have to start SGLT2 receptor inhibitors, low dose ARNI and low dose mineralocorticoid receptor inhibitor. And then we have to monitor, BP should be more than 90. Renal perfusion, we have to check urine output and everything. So if perfusion is good and renal parameter and potassium level is good, then we can also add beta blocker and up titrate the doses of mineralocorticoid receptor inhibitors and ARNI. And after optimizing on discharge, we can again increase the doses of ARNI, beta blocker, mineralocorticoid receptor antagonist and SGLT2 receptor inhibitor. Now, what if after taking all these drugs, patient is having worsening of heart failure? If patient is admitted again with worsen of symptoms and her kidney functions also GFR is less than 30, then what should we do? Then we have to hold these AC inhibitors, ARBs or ARNI. Even we have to hold the MRA also, and then we can continue SGLT2 receptor inhibitor. We can continue beta blocker, but in low dose. So if patient is taking beta blocker like 100 mg metoprolol, then we can reduce the half dose, 50 mg. But we should not directly stop beta blocker if any patient is coming with heart failure. And then we can add Vericigut, 2.5 milligram daily. In detail, Dr. Abhishek Rawal, I think, will tell you in details about Vericigut. Then after follow-up, we can increase the dose of Vericigut of 5 mg and then subsequently 10 mg. And if renal parameter and potassium level is good, then we can again restart the ARNI AC inhibitors and we can up titrate the doses of beta blocker also. So this is the summary of guideline directed medical therapy implementation in sequence in patients with heart failure. So this is the scenario where adequate or high blood pressure is there, but congestion is there. Then we can start ARNI, SGLT2 receptor inhibitors, mineralocorticoid receptor inhibitor, and last beta blocker because volume overload is there. If patient is coming with low blood pressure with congestion, then again first choice is SGLT2 receptor inhibitors, MRA, then RAS inhibitors, and then last beta blocker. If patient is having tachycardia, then if congestion is not there, then beta blocker is first choice. Again, I want to emphasize here, beta blocker is first choice rather than just starting ivabradine with we are thinking BP is low. So I think better to start beta blocker rather than just giving ivabradine. Then if patient is having tendency for hyperkalemia, then again SGLT2 receptor inhibitors and ARNI is first choice, and if still potassium is high, then K binders. And in renal impairment, again SGLT2 receptor inhibitors, ARNI and beta blocker should be the sequence for treating the heart failure. So this is the different case scenario I would discuss. Apart from this case scenario and these medicines, we have to tell our patient in our day-to-day OPD practice also. Some 3 or 4 point is very much important. First is patience. Doctor also should keep patience, and patient also should keep patience for heart failure, because heart failure is not the thing we can treat and we can improve the symptoms in 1 to 2 days or 1 to 2 weeks. At least more than 3 to 4 weeks is required to improve the symptoms and regain the day-to-day lifestyle. Second thing, diet. Already we are telling, but we have to emphasize more on diet and oral liquid intake for this type of patients, because minor change in this diet and liquid intake also can again precipitate the heart failure. And third thing is compliance. Compliance of the medicines. That is also very much useful, because if patient is not taking medicines properly, again heart failure. And third thing, last, we can also advise our patient to start exercise. Patient is having heart failure, patient improves clinically, then we have to at least start walking, not full exercise, but at least start some walking, whatever possible by patients, because it is also very much helpful in reducing the symptoms. Thank you.